Everybody, can I have your attention, please? Sophie, can you start the live stream, please?
Yeah, we are now streaming.
Yeah. Okay, good morning, everybody, and I'd like to welcome you to this meeting of the Trust Board. I'd like to start by introducing myself. I'm Janet Clark, and I'm the Deputy Chair of the Board, and I'm chairing the board this morning because our chairman is unwell. So to kick off, I'd like to just confirm that we've had absence from Mark Yates, from Elaine Clough, and from Matthew Hall. And I'd like to welcome Naomi here this morning, who is standing in for Elaine. Okay, so first item on the agenda then is minutes of meeting held on the 17th of July. Can I just check everybody is happy that those are an accurate meeting?
I've got one amendment that we just got. We missed off Denise Lewis on attendance because she was attending as Robert wasn't able to attend, so we'll add that in.
Thank you. So with that addition, is everybody content? Those are an accurate record? Yep, see nods, thank you. The action log has no actions, but can I just check that there are no matters arising that anybody wanted to raise this morning? This time I've got shakes, so that's good as well. I understand there have been no questions from the public. And declarations of interest is just the usual reminder we have that if anybody does have any declarations of interest that are pertinent to their role on the Trust Board, that they let Jill know. So just that we note that. And then that means that I move on nicely to our Chief Executive's report. Ellen.
Thank you, Chair. So members will have my report in the pack, and I don't intend to read through all of the things, but as usual with this report, I would like to pull out a few things for the particular attention of the board. So to start with, I think I would like to just take a moment to recognise that we have two changes coming up to our board. So Janet Clark, our Vice Chair, will be leaving the Trust, and this is your last Trust Board with us.
It is.
So I think there's a bit of a précis of Janet's extensive career, quite a short one actually in the report, given how much I know you've contributed to the NHS over the years. And you've been with us as a non-executive director since 2019. And I know that later on we'll be taking a moment to recognise the service of the Trust. So thank you, Janet, for everything you've done. And also Jill, our company secretary. So Jill has been with the Trust since 2015. So that's a decade of Herefordshire the Health and Care Trust. And Jill, although I've only joined recently, I've certainly picked up how valued you are by everybody in the organisation as a font of advice. And you have played a pivotal role in the development of our board, our legal services and our corporate. So I think, as I note in the report, Jill's role isn't going to be replaced, but this is absolutely no inference on the huge amount of value that Jill has delivered in her role. We're just going to take a slightly different approach moving forward and incorporating Jill's portfolio into a number of the other executive director portfolios. I think it's probably says something about Jill that we need to identify quite a number of people to take on all of Jill's responsibilities, including some new appointments. So how you've covered it all yourself, I'm not 100% sure. But thank you, and we will be having a proper occasion of your retirement, Jill, soon. So thank you to both of you. A couple of other things then I wanted to pick up. So we are working to develop our trust strategy following the publication of the 10-year plan. I've shared in the report our sort of emerging priorities, and we will be continuing to work these up with a view to bringing the strategy in the November Trust Board. There are also a few things to celebrate in terms of recent achievements. So the National Preceptorship Quality Mark And it's a recognition of excellence in supporting newly registered clinicians, which is really important and about ensuring that we are a sort of employer of choice for newly qualified clinicians coming into our system. We've also got an update around some visits that we've had from the Care Quality Commission, and there are some positive things on the whole coming out of those 2 visits, which is pleasing to see, and of course some points of learning that we will take forward. We've also noted some points of where people have achieved awards, which are some positives there. And I know we've also got, this is not in the report, but we've got our own awards coming up soon, staff awards, and it's been just wonderful to read about all the achievements that are happening across our organisation. So a couple of things then about the system. So we have recently seen the announcement of the appointment of the Integrated Care Board, Integrated Care Board Chair, get that in the right order. So Krishni Waring, who's currently our local chair of Herefordshire and Worcestershire, will be taking on the role of chair across the ICB cluster with Coventry and Warwickshire as well. At the moment, there hasn't been a formal announcement of CEO appointments to the clusters, but we know that Simon is currently seconded to cover that role at the present time. We have some other things around to note around the provider capability framework, and obviously we've had the NOF publication now with the trust league tables. I think the way I would identify our performance and sort of allocation to segment 3 is that I would have hoped that we would have landed in segment 2 with our performance, but we're aware of the small deviation from plan and the financial override rule. I think myself and Robert are really confident that that will not be the case in the next quarter, although that doesn't mean we should necessarily assume we'll move in segment 2, because it is a sort of relative allocation in terms of scoring. But I think we can feel reasonably confident of that, and we will just wait and see as we move forward. And one of the things we are thinking is how we really ensure grip of NOF metrics in each of our committees, and we can keep the focus on moving that forward. We've also got a note in here about the doctor strikes. I'm pleased to report that we saw little disruption and it was managed well by staff. But we should note that there is another ballot that is taking place, and we'll wait to see what comes out of that. A couple of things that I want to just mention that are not on the report, that have probably come up with more significance since I put the report together, is board members will be aware of the ongoing issues around the flags, the flags that we've seen going up around our community, and also the increasing level of kind of civil unrest that we're hearing reported in the national media. This is something that I've spoken about with in my weekly message, and we've been linking in with our staff networks. What we're hearing is that this is causing a significant degree of anxiety amongst staff and patients, actually. And we have also, disappointingly, seen an increase in reporting of racist incidents through our incident reporting framework. I think there's definitely a sense that some members of our society feel emboldened by what we're seeing, and that's really, really disappointing. So in terms of our response to that, I think there are a number of things that it's important for us to sort of keep upholding. So number one, our absolute conviction that we do not tolerate any racism, abuse, discrimination against our staff. Secondly, that we talk to our team, so we keep that dialogue open. We want to be a trust where values we uphold are that open dialogue, talking, raising concerns is absolutely what we want to support all our colleagues to be able and feel empowered to do and supported to do so. And I've reminded people of the numbers of ways that we can do that, including using our networks and our line management routes, etc., etc. And then I think the next thing is to remind people of some of the training and support offers we have to support with things like the active bystander training. So I've reminded colleagues of those opportunities, how we can support each other, you know, in these difficult times. And then I think the other thing that we've been just putting out there to teams is that we also do not, in our not tolerating abuse of our staff, we can withdraw care if patients don't respect our staff who are trying to provide them with care. Now that does get a little bit complicated sometimes around our mental health services, but as an organisation we have clear guidelines for that, and we can support our teams to understand, you know, the parameters of how we can manage that through. So these are all the things that we've been talking about through our senior leadership team, through our people and culture committee, with teams, encouraging all line managers to talk to their teams about these issues. So I hope that provides assurance that we do take this with the utmost seriousness and the importance of supporting our teams. I think the final point I would make there is that I think we also have a particular responsibility in the NHS, both because of the values of the NHS, and we're a large public institution, so it's important from that regard, but also because we particularly do recruit international colleagues to come and support our services, and they must feel safe, valued and supported as they go about their work on the behalf of us and the population we serve. Actually, I said that was the final thing, but I've had one further thought, and that is that we're also working with networks to think about how we can celebrate Black History Month, how we can do an event to really celebrate the work of our international colleagues, and thinking about how we can do that and raise the profile and share stories of our colleagues and the amazing work they do every day. So we'll keep working that through. But that's probably all I want to say for my report, and happy to take any questions on anything that I've raised today.
Any questions? Colin?
On the issue of the strategy, Alan, I welcome the fact that you highlight that we will be engaging with staff and that we will be looking at the impact we want to achieve, because I think for me that's perhaps equally important to getting the strategy objectives themselves right. It's what we want to see as an outcome. So I'd be interested in your views on how you're going to feed that through to the board in due course.
Yes, no, I think you're absolutely right, because, you know, you could have some grand statements, but I guess that kind of, what's the point? What are we actually going to be that's going to be different? So we're certainly starting to shape that up. I think we've got an opportunity to discuss further in the sort of soft landing in the October session. We have. I'm just, before I commit that we have, actually just double check my memory. And then obviously we'll have a much longer session on that in our November. But I would completely agree with your point that that is really a vital part of our strategy and setting out our vision.
Any questions, Dina?
Alan, I just wanted to thank you for highlighting and encouraging honest, open dialogue about how many of our staff and our patients are feeling right now. We did also raise it at People and Culture, and it's right that we acknowledge just how difficult these times are. And I think now more than ever, all the work that we've done in the past 18 months, compassionate leadership, kind life work, we've been putting together the building blocks for some time now, and that learning and self-awareness really matters now, doesn't it? So I think it's important that we acknowledge that. On a more positive note, it was really lovely to kind of read all the achievements, and we've got several external recognition in several areas. We've got the Preceptorship Quality Award, we've got the Barry Reynolds Award, and my favourite evening of the week is coming up. We've got the Staff Awards coming up. And I just wondered, you know, how are we ensuring that these successes are systematically shared to improve morale and recruitment and all of that good stuff. We've got a lot of good stuff going on as well.
Really good question. I might bring Sue in as well in a moment. I mean, I think it's important that we keep feeding them into our different communications channels. I certainly try and make a point of mentioning them in my weekly message. We have the regular staff briefing that goes out, and I know we try and post some of these things on our social media. She says not being a great user of social media, but I hear that is what we do. So Sue, I don't know if there's anything more you want to say.
I was thinking, how do we take some of the learning into our processes as well? So, for example, where we've got something around the neighbourhood team, when we're going into neighbourhood health, really understanding what has been successful in that space, what is it then that we could lift and shift, and then find a home for doing that. I think that's possibly, we want to celebrate and we want to put that, that motivation back into the teams to continue and to do more. But the learning piece, a lot of it is really understanding why does it feel like this here? How have we received the nomination? Why is it feeling successful? Getting that ingredients then into our plans and our processes is what I've been trying to do with the PMO and then with the planning process going forward.
Thank you, Sue. On ye.
Yeah, thank you. Thank you, Ellen, especially for the last part of your talk, because, of course, as an international doctor, it actually hits home because a lot of times, you have that lived experience. So thank you so much for making that statement, because it just gives me that assurance, that the trust is thinking about how you protect people like us. But I think my question is more around the Leng review and the PAs. So having that understanding of, when people order you, I know that it's been a really difficult time for PAs. So I'm just wondering how much of a risk is this for us in terms of, do we have a lot of PAs and AAs that we need to support? Because obviously it's going to be more intensive because they have to have supervision and all that. And number two, how much support have we put in to support them? Because now all of a sudden your job description and your title is going to change and there's so much uncertainty around it. So I just wondered if you could speak a bit about that.
Yeah, I think, John, would you be happy to take this question?
Yes, so we have currently one physician associate working with us. We considered the initial communication that came through, including the recommendation that of the designation change. However, I think that has been challenged, and we're waiting for some more guidance nationally around that. But the one physician associate we have working for us is currently part of the Worcestershire team and have the necessary supervision and support from within the medical directorate.
Thank you, John.
Okay, no other questions on the report. Ellen, I'll move us on. So I'm going to move on to the board assurance framework and clinical description. Jill, last time presenting this one.
Yes. How will I
miss it?
How will I manage in November? So you've got before you the board assurance framework and the high level risks. We have been doing a lot of work, and we've been working with our principal committees around trying to bring together the assurance levels on the priority programmes, the highest level risks, and now we've just introduced the national oversight framework metrics and allocated those to each committee. And I think one for moving forward is as we approve the new strategy, and we'll need to obviously look at then how we're going to deliver that. And so probably between now and next April, when we will probably then start reporting proper on the new priority programmes, it should bring a much greater clarity in terms of what progress are we making in terms of achieving our strategic objectives, because I think it's probably fair to say that at the moment it's a little unclear sometimes between our priority programmes and our strategic objectives, and therefore we sometimes struggle to identify what are the risks to achieving our strategic objectives, because I don't think we've quite got that clarity. So at the moment, I think we've done a little bit of trying to retrofit some of our priority programmes against our strategic objectives. But I think we're getting the building blocks in place for the committees then to take forward a much greater clarity. And at the principal committees, the last round, we had the discussion as to actually what the committees need to do to change their reporting, so we've got much greater clarity on how they're overseeing the receipt of information, so they can then assure audit committee in due course to trust board about, are we on track, are we off track, do we need to consider something else? I didn't intend to go in detail to the content in the report because I'm sure that everybody will have read that, but I'm happy to take any questions on it.
Jill. I mean, I think as a committee chair, I've certainly welcomed the changes that have been happening, and I think it's made actually running the committee a lot clearer and made the role of the committee a lot clearer. And I mean, I'm sorry I won't be here, but I'm sure that that will improve still further going forward. So absolutely endorse what you said. Any questions? You're both pointing at each other. Okay, Colin first.
I wouldn't with you to be lying on your deck chair, wherever you are, sunning yourself, worrying about the bath, Jill. But really, this is an opportunity for you to give us some assurance, which I hope you will, that this is sufficiently embedded in the psyche of our senior leaders that it will continue to thrive and prosper without you sort of being there prodding and helping.
So, I mean, inevitably there is, in terms of the cover after I've left, that's not entirely clear, but we do have some arrangements, contingencies in place. I think it's fair to say that the work that I've done, hopefully with Sue and with others, actually means that amongst the executive team, we probably have a much greater focus as to what are we seeking to achieve and how are we actually demonstrating that we're making progress on that, and actually how are we then through the committees and the reporting looking at how clear are we about how good the assurance is that's being received about various elements. So I'm absolutely certain that going forward somebody will hopefully take what we've got in terms of the building blocks and run with that, and you know, I think there's more to do. I think it's a bit like painting the fourth bridge, that you've got to continue with it. But we're in a pretty good battle rhythm now in terms of, through the organisation, the support and challenge about management of risk, whether that's at a lower level and reporting into integrated governance, or whether it's moving to a higher level. So I think that there's an awful lot of positives, and I'm sure somebody will run with this and make it better.
Thank you.
Yep. Beach.
I think my question was about succession more broadly anyway, but I think I'd make the comment that the committees, we should put some sort of timeline on the committees can head down on this effective way of establishing which priority programmes are being fed into which committee, monitoring them and assuring against those. So I think we've only just started that process, but I think we could all probably benefit with some timeline and accountability being put in place for that.
I mean, I think actually one of Colin's ideas about reporting to audit committee will be really helpful with that, because it's obviously work in progress, and I'm sure each committee chair will find their own way of dealing with that and how they're presenting the information to audit committee. But actually, I think it gives quite a good discipline in terms of each committee chair attending in rotation and thinking about how they're going to give assurance that they're running their committee in a way that is able to then provide assurance to audit committee. So I think actually that cycle will be really helpful. Inevitably, once we get to the new financial year and probably we switch to reporting about the new priority programmes, I think it will almost be a good opportunity to take a bit of a pause and reflect, do we think we've got this right now? And that inevitably at the end of the financial year, I would anticipate that there would be a look back about, do we think we've made progress? And at some point in the future, probably the fairly near future, in 2026, there's probably consideration about an external well-led review, which obviously would look at this as part of an overall package. But I'm sure Sue probably has some views as well.
Certainly, on the last cycle of committee meetings, I did take an action to pull in chairs and the lead execs for each. And part of that was to do a bit of check and balance around what people are reporting into the right spaces. But I think we recognise that some of the we've got to give it a primary home, so it's probably an art, not a science. And I'm quite comfortable with that as long as we've got some commonality on how things are flowing in the reporting. So, and I do think, Jill, you've done a sterling, she's made me quite excited about that.
Jill, achievements indeed.
Yeah. So for me, then there is definitely something about we've used this recent side, haven't we, really, to test and learn, and I think we're in really good shape then when we get the new strategic objectives to then think through how do we use the process we've got. But I think it does need to be much more about the priority programmes we're confident are going to deliver the strategic objectives, rather than potentially having priority programmes and then giving them a home, which is sort of a little how it's felt to date.
Yeah, that's absolutely right. I think I would endorse that. But I think it's clear it's an iterative process, isn't it? But I feel confident that with Colin and the audit committee, and I noticed he got his pen out at one point, so that reassured me tremendously. That actually this will not be allowed to slip at all. So
No pressure then.
no pressure. Okay, so I don't see any other hands. So I think we just need to approve the BAF. So can I just check the board's happy to do that? Very much. Okay, I'll move on then. Oh, so this is really timely, isn't it? Good agenda planning here. So we're onto the strategy and partnerships, and so
it's the priority programme paper. Thank you, Janet. Yes, so I did attend all the last 3 committees, and in part that was to test out some of what we've just been describing. So what we've tried to do is to give the NOF metrics a home, obviously triangulating that to the strategy and the priority programmes. So they will all now run into a space that is namely a committee, but in something under P&B. So just to say then, what you have in front of you is that check and balance that's actually already gone through a formal structure in the trust, reviewing the previous assurance ratings and then levels, and then saying where we've landed now. So I wasn't going to get into the detail, but I was just going to pick up a few areas where things might have changed since the report's been written. And on the note of celebration, I did want to pick up about the patient and carer voice and the implementation of care opinion. So to say that had its formal launch, and obviously we've had it now for a while, but we've now got all services pretty much via our Section 136 suite on care opinion. And I was saying earlier, we've got, as of yesterday when I looked, we've got 796 stories, but these have been viewed 42,300 times. So that's a reach, and we're still early on in the journey. So we really need to think through how we're learning about what is it that people are wanting to get from reviewing and reading those stories and understanding people's experiences of our care. So that's all really leaning in the right direction. The next process around that will be to go back round with the teams that possibly haven't got the same level of engagement or haven't got the same stories coming through. We have got some real front runners. I would say podiatry do very well. So do many of our neighbourhood teams, and I would also reflect those who are particularly great engagement or feedback previously through things like the Friends and Family Test. So we have got a place now where we're hearing feedback and stories which we didn't have prior to rolling out the care opinion programme. So I also then wanted to just pick up around the out of area placements, and to say as of Tuesday we've done 126 days with no inappropriate out of area placements for adult mental health. So congratulations to everybody that's made that happen and managed to sustain that. The community hospital inpatient length of stay, that's mobilising as expected, and now that phase 3 will be scoped with partners. That'll be next month. You'll notice you've probably got more detail on the community paediatrics therapies and nursing programme. That is because we've done a deeper dive, myself and Matthew, throughout August, and that was really in preparation for the SEND stop check, which is happening in Worcestershire next week. Ellen and myself attending that meeting on behalf of the organisation. So we just wanted to make sure that we were really comfortable on the 4 work streams, where we were, where we needed to put in additional resource or focus before we go into the stop check in the system. So there's a more detailed piece to give yourselves assurance there on exactly where that's landed. And then finally, I wanted to pick up about the adult mental health rehabilitation redesign, and to note that we had the NHSE sense check meeting on the 2nd of September, and that went well, didn't it, John? There was feedback that today all of the work's following the process. It's been very comprehensive, and now we can move forward to the options appraisal, which is happening next month as well. So those were some of the headlines I wanted to pull out from the paper.
Thank you, Sue. I think the care opinion has been dramatic, actually, hasn't it? I remember when it started and we were just getting one or two, and now it's just seems to be snowballing. So I'm really, really, really pleased to hear that.
Great. So, well done to the team.
Yeah, absolutely, absolutely. So, any questions, Viv?
Yeah, I just wanted to thank you, Sue, for the clarity of your paper, because it's really encouraging to see not just the challenges that are set out, so the evidence of progress. I think that's really important across several priority areas, and I think that visibility that makes a real difference for the board in understanding where we can celebrate success as well as keeping an eye on the risks. And again, I want to congratulate everyone on the work around care. It's fantastic to see it. I have to hold my hand up to this because I remember sitting at board a while ago and questioning whether this would become sort of a trip advisor for healthcare, and would it open us up to unhelpful and unjustified criticism? And it's the opposite has happened, hasn't it? And I think we really need to acknowledge how successful it's been. We're getting, real-time feedback, most of it positive, and actually when people do raise concerns, it's constructive and helps us to improve. And I think the fact that it gives patients and carers a stronger voice has got to be a win for everybody. So thank you. This is something that we should all be of.
And it's definitely created a different space between a formal complaint and something which was quite binary around friends and family. So when you read them, a lot of it is a testimony to say thank you. And when there is feedback, it's often around the things we know, like the communication could have been better. One of us turn the telly down in the way to move, and the staff just go, yeah, of course. That instant learning, instead of having to come in corporately, potentially go around the organisation, people, and they can respond. And the take-up of the responders has been great. And we've had so much enthusiasm in that space. So, yeah, onwards and upwards, it feels really good.
Actually.
And I think it's that non-corporate response as well, isn't it? It's the teams themselves. They don't need to ask permission. It's not screened by anybody. It's a very natural, here's my feedback, here's our response, which is really lovely. The staff will take ownership of that and speak freely as well. Good bonus.
Yeah, ownership was the word I was going to use. I think it's getting it right at the right sort of level. So, any other questions? So, Colin.
So on the part that deals with community paediatrics, the last bullet point says that you've captured the word today. So that going forward, that these will be the minimum assurance levels. I wanted to understand what you're trying to tell us with that. Are you saying that we aren't really where we ought to be with this at this point in time?
So the work we wanted to do, which span out of what I think was an assurance level for the programme, to disaggregate the programme. It is a really complex multifactorial piece of work, and it's got a number of pathways. Some are easier for us to mobilise on our own, and others we really have to put into the system space, and that's been moving forward. So you'll see what I did within that was to say that, for example, the enhanced health and care plans, education, health and care plans, we've made a lot of progress in that area, and we've seen the wait times come down, satisfaction go up, and we've been able to now pull that through, and that's evidenced in the system. That's also true for the rollout of the balance system, which is really about better wait times for therapies, so OT and physio in this case. The work that we're further behind on is the broader clinical model. So that's the pathway work, which we went through in more detail. So these were the assurance levels because they were ratified at the programme board, not at PMB. So I'm expecting them to be the minimum because they'll also be out of date because we'll have another programme board by the time we get to PMB, which is next week. So this was the minimum. And then some areas we may well see an improvement.
Colin, did you want to come back?
I'm just seeking assurance on having light at the end of the tunnel, I suppose. So if we're at the minimum now, when do you feel comfortable with these very difficult working areas that will be making the progress?
Again, I think you're going to see the balance programme moving forward with some pace, and then we've got the ongoing issues really sit about the ADHD and ASD pathways, and that is the ongoing challenge that we have. We've committed some additional resource to do more work into the wait times and clinical validation. We did that last week, and we want to make sure then that we can start to putting some progress around that over the next 6 months, but the demand is obviously significant. So that's the piece. That's the one I think that would also keeps us awake at night. The other piece of work less so. I feel assured now that we have a plan, we're moving it forward, and we've got the right people and the right resources in the space. So it is that ASD and ADHD piece which is still concerning.
Thank you. Yes. Thank you for that report, Sue. Good journey. Positive. Sorry, I was looking at the screen. Oh, Anya, you sneaked a hand in. Yeah.
No, I know. I'm terribly sorry about that. Thank you so much, Sue, for the report. And yeah, it's actually quite good to see all the priorities, and I really enjoyed that. Can I just ask you about the temporary staffing, if I may, because it talks about we are above target at the moment, and our locum rate has gone up in some directorates, and I'm just a bit concerned about, I mean, we're about to go into winter, so, and we know winter can be difficult. So what assurances do we have that we now have the grip on this and it's not going to spin out of control as we're going into winter?
Natalie, you've been all over this. Do you want to pick this up?
Yeah, I'll leave the locum agency rates to John. That's predominantly medics. I mean, the programme's had grip now for well over a year on Yay, so I don't think it's a recent grip. It performed trajectory last year, and we've continued that this year. We've got 5 key priority programmes within, or 5 key measures within the programme. We've got really good engagement by the teams. They come up with change ideas to meet those priority programmes. Every meeting we have, we monitor those really carefully. We take a really strong QI approach to it. So we were just out of trajectory last month, but that's been the first time for a while, and we understood the reason for that. So we've had a really strong success rate in reducing agency and substantially recruiting agency staff into posts. It's our temporary staff spend now that's a little higher than it should have been last month. And again, we're working around how we do that, reducing vacancies. There's a whole raft of kind of quality initiatives to keep it on track.
Thank you for that.
John, did you want to on the medical?
Yeah, I mean, with the medical agency reduction, we've been undertaking quite a few different initiatives. So we've got all our engagement with agency doctors are through agile workforce, which provide an intermediary. We've also managed to get most of our doctors on the West Midlands cluster rate, so that's kind of agreed across the West Midlands. The on and off increase or decrease in the agency spend on a month-to-month basis is quite unpredictable. It's due to sickness, and that will be monitored accordingly by the graduate support team. And I think overall we are on track in kind of achieving the annual target, but there's obviously the month-by-month variations that sometimes happens due to unpredictable absences.
Thank you, John.
Thank you, Anya, for that question. No other questions then. Thank you for the report, Sue. I'm going to move on to the operational update, and Ellen, I think you're doing that one for Matthew.
I am, yes. Thank you, Chair. So a number of areas in the Chief Operating Officer's report actually follow on from Sue's report. So I won't repeat some of the ground that has already been covered, but I will just draw out a few points. So I think we've just talked about some challenges in the children's services, but I think there's just probably one additional thing to pull out of Matthew's report, which relates to the CAMS LD service, which is particularly challenged at the moment. So we're working on mitigations for that, but I guess just to flag that is a particular area of challenge. I think 2 things. Firstly, I've gone through in detail with Matthew. I know he's got a really comprehensive plan around kind of shoring up the current position around some additional clinical supervision, leaning in and supporting colleagues and making sure we're managing that safely. And I also know that longer term, he's got some thoughts around how we can transform that service to be more resilient in the future. So I think it's both of those things that we need to do, which is kind of shoring up the here and now, but also thinking about the model of care, because I think part of the reason we've sort of landed in this position is because the model probably needs a bit of a root and branch review. So we're going to do both of those things. The other thing I thought I would just draw out, because some of the elements of the urgent and emergency care update came out in Sue's report, but not all. One of the things I would like to particularly draw the board's attention to, that we did achieve closing the surge and boarding places by the end of July 2025, and that was actually the first time since October 2024 that the community hospitals have operated within their normal bed allocation. And we know that was a really important thing for our patients in terms of being in the right quality of space, but also really important for our staff working in those areas, who I think it would probably not be too strong to say felt a degree of moral injury about some of the inadequacy of the areas they were nursing patients in. And that's been really important for colleagues working in the wards to feel that we were able to move out some of those spaces which were designated as temporary, but you can see over that duration and has not manifested in that way in real life. So I think, you know, that's not to pass any criticism, because we know why we were there, which was around trying to do the right thing by the system. But it's just, you know, recognising some of the difficulty that was causing in terms of giving the quality of care that we want to give to our patients. So it's great to see that having been achieved. And also, I think the important thing to flag is that we've maintained pathway 2 throughput as well in that time. So that is a significant achievement, and has also involved matrons across all of our wards, our ward managers, really owning that and moving that forward to delivery. And I think probably just the last thing I'll flag is that we've been doing a lot of work on winter planning, and I'm going to present that paper shortly as well. I also joined Matthew and John as well at a 3-hour winter assurance session with the region. And I think a couple of the takeaways from that were the region noted that the plans were robust, albeit I think we all feel there's a degree of fragility around some areas that we're still working on to improve. So, you know, the work doesn't stop with the stock take, we're continuing, and we know what those areas look like. I think what was particularly pleasing is that it was noted how collegiate it felt in terms of the system presentation, and really good joint working with ourselves, our acute trust colleagues and the ICB, and the region commented that from their perspective, having visited a year ago and coming back in, they could really sense how much that had moved on in the relationships that are building across the system. So just wanted to share those positives. So I think we're under no illusions that it's going to be tough. The conditions in the NHS are tough across the board at the moment, but I think we've got a good plan, and we'll keep working on it to try and ensure it can be as robust as it possibly can.
Thank you, Ellen. Any questions on this report?
Quickie. Oh, sorry.
Okay, Beach,
Go
you go first, Beach.
Just a quick one, and it may fall into the finance section, probably more so in terms of the financial implications of when we were running Surge. Clearly had a massive impact, actually, but also importantly had quality of care, staff morale, and all the rest. Are we happy that we've worked out what the causes were and the fact that we've got a chance of preventing such surge, or are we likely to see such surge and beds open up again because we'll have to, especially because of this winter, or is it just off the table?
I think Ellen can take that, because I think it's probably covered a bit later on this.
Yeah, I'll cover it in the winter plan. I think the important thing is to say that, as far as I'm concerned, it's off the table unless we're in an exceptional major incident, and it's all that sort of stuff.
That's just what I wanted to hear. Thank you.
Yeah. So
But just to add that last week it was confirmed that we've been awarded the Baby Friendly Initiative under UNICEF for our breastfeeding services, feeding services, which is great. So there's been a lot happening in the 0 to 19 space. I just wanted to bring Natalie in, really. You've been closer to some of this, but it mentions there around the evaluation, which is really important, and that can just give us a little bit more assurance around what that looks like.
Yeah, so thanks to you. So at the very start, we said that we'd make sure that we evaluated the new model properly. So we've already started to engage with the staff around what that looks like on a month-to-month basis now, but that in 18 months' time, we'll have a designed proper evaluation process where we're looking at the model from an outputs, KPI, experiential, from both a staff, young person and family perspective. So we're engaged with the ICB and Institute of Health Visiting to see how we can do that. So I think there's that reassurance the staff who are worried, obviously, about the new model as we've discussed. But yes, you can talk to us on an ongoing basis, but there's a proper evaluation built in as well.
Thank you, then, Ellen. Thank you for that report. And Scott, the improvement plan.
Fantastic. Well, thank you very much, Chair. So the report you've got in front of you is going to be the final report of the improvement plan. So when we set off on this journey as a board, we'd heard from CQC, 1,000 of our staff contributed, which then led to the development of the improvement plan. Now, at the time, we said the improvement plan would have an 18-month life cycle and be really used to get us focused on some of those key issues, get us moving forward, but then would have to be moving those key topics into other pieces of work. So what you've got in the report is, in many ways, a little bit of a celebration of what we've achieved, but also a bit of realism of what we need to do going forwards. So when we're looking at the staff survey and the culture score, we can see clear statistical improvements in key areas such as our culture, such as my immediate line manager, and things like recommend the care and recommends a place to work. That does, though, not mask that we've still got a long way to go. So as we're going into the next cycle of a national staff survey, we have to recognise that we've been on a journey which for 5 years, year on year, our staff survey declined. Last year, we reversed that and went back above average with one of the metrics and the others all starting a small improvement, which we haven't seen for a long time. So it is really that thing of we need to really keep this work going over a long period of time. Some really key successes there in terms of support and development for line managers, although further still to go. The compassionate and inclusive culture work, which we know if we get that right, we have a staff are better able to deliver high quality care, better able to drive improvements. Obviously, that's a key feature going forward. Final bit I just draw attention to is that during the next period, we will be moving this work into other areas. So the culture aspect will be part of the trust strategy, as well as being a feature of the people and culture strategy that will follow there. Governance, again, continued work to strengthen our governance, sat underneath the Director of Nursing and Director of Operations and Transformation. And also really those core elements we discussed already through Sue's paper of patient voice. So it's fantastic we're getting those individual stories and dealing with them really, really well and learning from them. It's then about, right, so what are the themes within there? How do they come together? What's the stories that telling us? And really making sure that's being used to drive our transformation, drive our improvement work, and of course, drive that experience for patients. But overall, I think we can go through the paper, lots of great work by an awful lot of people. And it's now about us really, really embedding and really, really making sure it's part of everything that we do for every single one of us.
Scott, any questions?
Yeah, I just want to say thank you for your report. all the work that's gone into delivering the improvement plan over the last 18 months. It's really clear how much work has gone into this when involved. And it's particularly encouraging to see sort of that 5-year decline in the staff survey results, improvements in engagement compared to our peers. That's been really good to see. But because this is the final formal improvement plan report to board, I think the question for all of us now is around sustainability, isn't it? And how confident we are that focus on staff voice and compassionate culture and inclusion, how they will continue to be measured effectively through the new trust strategy. And also, I mean, for me, my concern is how will we see kind of the early warning signs at board if progress begins to slip? What mechanisms will trigger corrective action?
Should we do a little bit of a double or triple act here? I think it's very thing. So I think as we go forward, we have to be making sure we're using this information effectively through our integrated governance and really understanding what is it we're doing at that granular level with teams to make sure this is business as usual. And then for me, the Pulse survey, the Pulse dashboard, that's something that continues. One, it's a bit of an operational tool for being able to understand where there may be hotspots, but also to be able to give board assurance. And I don't know whether this.
Yeah, so I think as part of the Pulse dashboard, there is now being developed kind of early warning signs. So if certain metrics are showing there is potentially an issue, it will flag up. I think we're also ensuring that we're working across all the different teams. So we're getting together on a regular basis to say, are there any teams which have reached out for support, or are there any concerning metrics? What else might be going on and what support can we give? And I think with the people, partners in place and feeding into those integrated governance meetings, that's also a really good place for those things to be raised.
So we're being much more proactive rather than reactive. Anything else?
Sorry. I mean, just to add that, I think we've got to remember there as well is the strategy is critical in this, and clearly we've got opportunities board and with our colleagues to just kind of shape the final part. But part of that, there's been various discussions are around so how do we know that we're getting there? So particularly if we talk about one of the priorities that's likely to be in there, which is around creating, enhancing, embedding that culture. I think there is a good point there about how do we know we're getting there, what are the slides. So there's lots going on there, but I suppose there's an opportunity just to draw that together so the board's content as well.
It feels like we've got sharper focus on the right things now. I think that's important. The improvement plan when we first looked at it was extensive, if you'll recall, and I think we've distilled it back. There'll be lots of things going into business as usual, and as Rob said, we know now that we've got to crystallise those 3, 4 or 5 things in the strategy and then really deliver on those. And thinking about how we then pull through the impacts in the October session would be really.
Did I see anything else? Okay, I'd like to echo Vina's thanks, because I think there has been a lot of work done by yourself, Scott, and by your team. But I think it's really important that the point she made about not being complacent really is one that we need to really take on board, because it always worries me when we close the report down that we lose sight on that. But I think I've got assurance from the questioning that actually that will not be the case. So I think that's really key that we brought that out. So
there's a lot of things that have in that report which have come from staff voice, and it's absolutely vital to keep on moving those forward, and it's it's about creating the environment where staff are best able to deliver the best possible care.
Okay, thank you very much. So move on now then to the item that we sort of flagged a minute ago about the board assurance framework into planning, and this would have been Matthew, but I think Ellen, you're going to
talk to this, and I was involved in the production of the report as well. So happy to take any questions. So So there are a couple of things that we're just doing with this report. So firstly, there is a requirement from NHS England that we complete a assurance checklist effectively for the winter plan. So that checklist is included. We are able to answer yes to all the questions at this point in time, other than the full completion of the QIA, which is underway at the moment. There is a number of questions. I'm happy to answer any of the questions anyone might have about the assurance, but we've gone through and assessed that, those questions. There is then a sort of relatively short version of the winter plan. One of the things that I've been talking with Matthew and David about, who largely produced this plan, is how can we produce a version that would be accessible for staff. In my previous system, I was the director for urgent and emergency care as well, and we produced a public-facing, really accessible version of our winter plan, which was also then for all colleagues of the system. And it was really helpful in terms of setting out our stall for what the key points of our winter plan were. And I think it's going to be more accessible for people than, you know, the reality. How many people will read this document? Probably not that many. And therefore things like our position around surge, our approach to beds, etc., might not be as clear to everybody, because that is quite a big culture change that we're trying to create around some of the things in this plan. So communicating it, providing opportunities to talk to teams. You know, we printed off hard copies and left them in nursing areas, things like that. That's an important part, I think, of what we need to do next, as well as communicating to patients who are using our services some of the important features of our plan. So I think, see this as a work in progress. We are, I think, if you're content, able to sign off the assurance statement to kind of meet that requirement. But what I'd like to do is be coming back to share a public-facing, colleague-facing version, ideally in November, at November board. So my aspiration would be that we can bring that back and share it with them.
Thank you, Ellen. And that was particularly my question, because I think the issue of that survey is really important. Scott and I went out to Tenbury Hospital, didn't we? And they showed us where those would have been. They actually reported back to us, Ellen, that you told them that that wouldn't be happening again. And they, unicorns. Yeah, that's right. Yeah. And they were extremely pleased about that. But my concern was about how do we communicate that message out. And I think you are absolutely right. Getting a more accessible document is really important. So thank you for that.
And can I just add something, because I know people are waiting. I guess one of the things I would just share is that I've lived through this transition in my old system, so I feel really confident it can be done. I think, but we shouldn't underestimate it's hard, like weaning off the response to pressure as we open more places to put people will take some time. It doesn't achieve results, but I've lived through the pain once, so I feel more confident this time taking that stance. But I know it's going to be something we're going to have to work on together as a system. And there are some other things that I'd like to come back and share, perhaps in the next. I think it would be helpful for us to keep a kind of winter update rhythm going through the next few months. And there are some things that I would like to share with you about some further thoughts we've got. As I said, this is point in time, work in progress, but around more shared approach with our acute trust colleagues about how we work together around the mitigations. I think there's still more we need to do on the mitigations. I think it's a really good start, but we need to keep working on it. It's this live work in progress type territory, really.
I've got a number of questions, I think, so I'm going to start with the ones on the screen. So Sue, if you can be first.
Thank you. Well, I really welcome what Ellen was just saying there about the way that we're going to keep highlighting this and working with colleagues, because it just seems to be something that every year comes around and causes major disruption to our services. I've got 2 points which concern me. One is about the lack of COVID vaccinations for our staff, which obviously is a national decision, but I just wonder whether people around the table think that's going to have an impact at all. And the second is the unintended consequences of things that we do when we go into emergency procedures. So we were talking at the equipment centre recently, Natalie and I, and they were saying that, you know, when we get into sort of gold, it's impossible for their patients to get out of their building with the ambulance, because all the ambulances are being used to sort of move people from the acute, which we can understand, but there are knock-on effects for our different services. And I just wonder whether we should be beginning to compile a list of those unintended consequences and what our mitigations are going to be in those cases.
Thank you, Sue. I think Natalie will take the one about the COVID.
Yeah, happy to take the vaccination question. So every year there's a committee called the Joint Committee for Vaccination and Immunisations that looks at the efficacy of the vaccines and what's going to be promoted for that season. I mean, it only just was recommended last year. It was very borderline, and there's real clarity now around uptake rates and the consequence of getting COVID being very different to obviously 4 years ago. So no, I don't think we have any concerns around that being part of the winter vaccine programme. And we really need to put all of our efforts into ensuring as many of our staff get the flu vaccine as possible. And that should be our priority focus for this winter plan.
The question about unintended
consequences of the equipment service and the gold. So I guess that there isn't an easy, quick answer to that one, Sue. I mean, is this a little bit that kind of, what was that Richard III poem, you know, for the want of the nail? And we do sometimes tie ourselves up in that knot where for the kind of want of something quite simple like a riser chair or a commode, someone is in a very expensive hospital bed. So I think the short version would be, we're aware of the issue, something we need to crack. How do we, I think there are some ideas around things like, you know, some rapid access budgets, things we could quickly pull in, you know, having a supply of things that would help. Sometimes these are, you know, I heard when I went to the Evesham Community Hospital, for example, about the increase in the need for bariatric support, things like chairs and so on, often preventing discharge to nursing homes or delaying, highly of course. So I think we're aware of it, some creative solutions being discussed. I think there are some broader issues with community equipment service that we know about that could tolerate some improvement, let's put it that way. So I don't have a quick answer for you, but definitely on the radar. Thank you.
Onyi.
Yeah, thank you. Thank you, Chair. And thank you, Ellen, for the report. Actually, Janet, I liked your point about communication. I think the most important thing about this is communication, because sometimes we have all these plans and somehow they don't get to not just our staff, but actually our patients and communities, because more than anything, we need winter, you know, everybody on board in winter, not just us, but also the communities we care about. But Ellen, I just need a bit of clarification, if you don't mind. You talked about fit testing. We seem to have done the fit testing, but we've chosen to put it on the spreadsheet rather than the ESR. I'm just wondering, do we understand the rationale why we decided to do that?
So which bit is this?
It's around fit testing for the masks, so we don't.
Yeah, IPC, considering it's something that is long term.
I mean, it's a very pragmatic. It was a solution at the time that we've kept. It keeps either process would be absolutely fine as long as you've got one and it's working for you. So the sense was that the spreadsheet was what was put in place in COVID. It's worked really well. There's no local issues with it, so that's what's being maintained at the moment.
Is that electronic or is it paper?
It's an electronic spreadsheet that teams maintain, and the IPC team have an overarching.
Okay, and do we have any plans to move it to the ESR?
Not at the moment, just because of other priorities of things to go on to ESR.
Thank you very much.
Thank you, Natalie. I think if the IPC team are keeping an overview on that gives me assurance. They won't lose sight. Natalie, I think you had a question yourself.
And I guess it's just a comment that, or a reflection that Matthew, James, our interim associate director, and I have had a really good conversation around some of the language in the plan that we might not choose to use, but that's kind of system-based. So I really battle with them, and I think we reflect that actually this isn't a battle. This is a really difficult period we're about to enter in. That learning from the last couple of years, we need to emphasise more on moral injury and supporting compassionate leadership and compassionate involvement throughout this winter plan. So again, we're just thinking about how we can wrap an increased level of support around every layer of staff working through the system this winter.
Can I just add to that? Because I think it's a really, really important point. I just want to enhance something about it. So I think your point is really well made, and there's something about how we take this and make it into something that's more a better comms document, as we've mentioned. But it also brings to mind something that I've also flagged back myself, which is, again, from my experience in my previous system, so forgive me for bringing that in again, there was a really important, what I would call OD piece of how we worked around winter. So where were we creating space for teams to come together to work in a non-crisis environment? So building relationships with the operational leads, supporting people to have the conversations about how we're working together, shared ambition around the things we want to achieve, not my gain, your loss, which it used to feel like until we did some of that work, and could still tip back into some of that. And putting the patient at the heart of how we were talking about the challenges in winter. So in Gloucestershire, the language that worked for people was delay-related harm. So how do we work together to minimise delay-related harm for patients? I personally was a little bit on the fence about that one. I think but it's language that works for the clinical teams and the operational teams involved. So I've certainly started a conversation about how do we create some space for that? How do we find a common currency where it's about the patient, not about, my pressure, your pressure, and everybody's in it together trying to solve the problem. So, and that speaks to some of the shared roles and things I think we want to put in. But I think your point about some of the language is really, really well made, Natalie, because we need to support people to work collaboratively on a difficult problem, not be in some of the maybe difficult conversations that we've had. And I think that compassionate leadership work has a real offer that we could make into this as well. So yeah, very important.
Thank you. So before we move on this, I know that we have to approve the winter assurance return, so that could be submitted. Just check that all is submitted. Yeah. Sorry.
So very quick question, because we're talking about assurance. I noticed that quality impact assessment has been completed, but the equality impact assessment is still pending.
Yeah.
It will be done in time. I mean, just given that older people and those with disabilities are more likely to be affected by winter pressures out there, I don't think we should lose that detail.
No, it's really important. I would agree.
So subject to that, we're happy to approve. Yeah. Okay, thank you. Right, final report then before we have a break, and that's welcome to Natasha. Thank you for coming along to present your report. Your report's been already to People and Culture Committee. I think we've had it included. But if you'd like to present it now for the board, that would be lovely. Thank you.
Morning, everyone. Yes, so as Janet said, the paper's already been to People and Culture, and I'm taking it as read because I appreciate we're on timescales this morning, including obviously there is an executive summary that gives key highlights. So I won't go through that, but what I did want to do just before I do ask for any questions is just some highlights from me that I think are really important. The paper, when I wrote it, didn't feel very different to the paper that was presented in March, and I think there is good reason for that. We are obviously on a journey with freedom to speak up, and I think it's the first time we've got to a point where I think we may be settled into the work that we need to do. So That's not to say that we don't have a long way to go in terms of the work we're doing, but I think it's also a really good point to recognise that we have come a long way as well in terms of the work that we're doing as an organisation. I also feel that we have got to a point where we've got quite a solid database to make action plans on. And when I came in and presented my paper in March, one of the actions that came out of that was to create a new action plan for us in terms of freedom to speak up. And that was only signed off in May. So although we're in September, that action plan hasn't been in place very long. And my feeling, which I've put into the paper, is that actually we need to let that action plan run now before we can sort of reassess where we are in terms of our speaking up culture. And that's because we know that change around freedom to speak up isn't quick. We can make quick wins and quick gains, which we have made a lot of. But in terms of culture change, we know that that pace is much slower. So that's really what I wanted to say. And obviously, there's any questions from that today? Okay, in that case, Ashley, I'd like to actually pay tribute to you yourself, because you said yourself that we've come a long way. And I think that is in large part down to your leadership in this area, which has been excellent. So on behalf of the board, I think we'd like to congratulate you on that and the progress you've made, but obviously recognise that you've got your action plan and we're anticipating yet more progress will be made. But thank you very much indeed for coming. So that brings us to the break, which I think is well earned. People, so it's 11:22, so I suggest we come back as close to 11:32 as we can manage.